Madurai, and he's an avid surgeon and actively interested in clinical and translational research. So he has a strong advocate for diabetic retinopathy and myopia awareness, and we are looking forward to his talk on the non-capillary perfusion areas and the reclassification of diabetic retinopathy. So over to you, Dr. Sagnik. Looking forward to your talk.
Hi, sir. Thank you for the introduction. Can you hear me?
Yeah, we can hear you. We can't see the screen.
Yeah, I'll just share it. Yeah, can you see the screen?
Yeah.
Okay. So I thought I'll bring an interesting topic today for discussion. So today is about reclassification of diabetic retinopathy with a focus on capillary non-perfusion. So as you all know, that the International Clinical Diabetic Retinopathy Disease Severity Scale has divided diabetic retinopathy in these 5 stages, which are no apparent retinopathy, mild, moderate, severe, NPDR, and proliferative diabetic retinopathy. This is like every resident which is passing out of a medical school, they know this classification. So this classification was based on the diabetic retinopathy severity score, which was decided in the Early House meeting in Virginia in 1968. So that was 54 years old. And the classification was based on 7-field stereoscopic film-based fundus photographs. However, later on it was realized that the 7-field photograph was almost equivalent to a 4 wide-field digital photographs that we use today. So this is just an overview of the classification. Mild to moderate NPDR was levels 35-43 on ATDRS DRSS score, which included intraretinal microvascular abnormalities, hemorrhages, microaneurysms. Levels 47-53 were moderately severe to severe NPDR. Again, patients would have intraretinal hemorrhages which were more severe and including all the quadrants, then venous bleeding, intraretinal microvascular abnormalities, lipid exudates. And 60 to 75 would be moderately severe to severe PDR, where we'll have neovascularization. This is again another infographic. So the DRSS score would range from 10 to 12 up to 85. So below 47, the previous scores would be subclinical DR. And 47 to 85 onwards, we'll have moderately severe to severe NPDR, then mild moderate PDR, and high risk PDR. So as you know that the conventional treatment strategies for PDR is panretinal photocoagulation, and for diabetic macular edema, it has been anti-VEGF. But nowadays, we are getting a lot of studies which have started evaluating anti-VEGFs for DR itself. So these are some of the later studies from Beetham Eye Center, Jocelyn. So they started evaluating more peripheral retinal lesions on ultra-wide field color fundus photographs like optos. And they said that peripheral retinal lesions could better predict the risk of DR than conventional ETDRS photographs. So this ETDRS 7 standard fields you can see in the center, and these are the peripheral fields. So they divided lesions into predominantly central lesions and predominantly peripheral lesions. And later on, they also measured the capillary non-perfusion on ultra-wide field fluorescein angiography. And they found that DR peripheral lesions were associated with the severity of diabetic retinopathy. So in this chart, you can see that as we progress from no DR to PDR, the diabetic non-perfusion index is correlating quite well with the severity of DR. Here you can see wide field angiography photographs which are showing peripheral neovascularizations quite well. And here you can see in the right side photograph, you can see comparison of fluorescein angiography and non-dye based OCTA, wide field OCTA. You can see in both the photographs that the OCTA picture is showing us the capillary layer a little bit better than fluorescein angiography. Then the DAVE trial came, which evaluated total retinal non-perfusion, and they found that non-perfusion was greatest in the mid-peripheral retina. And they also evaluated that capillary non-perfusion was correlated well with vascular leakage in all 3 retinal zones. So coming to the role of OCT angiography in all of this. OCT angiography is able to image retinal vasculature with different retinal layers at resolutions which are not possible with fluorescein angiography. And as we all know that OCTA cannot demonstrate leakage, but it's a benefit for us because it allows the imaging of capillary non-perfusion better, which may be masked by leakage. And OCTA also is more reliable for correlations between DME and biomarkers of interest, including non-perfusion. So this is one paper which we did. This was an exploratory review article on diabetic macular ischemia and diabetic macular edema development. So we can see that diabetic macular edema develops as diabetic macular ischemia first. So non-perfusion appears first, leading to breakdown of blood retinal barrier, leading to superficial capillary loss, deep capillary plexus loss, and finally, what we see is diabetic macular edema. Coming to role of anti-VEGFs, as we all know that anti-VEGF blockade has been used to reduce retinal edema. So VEGF blockade is also being proposed to help reverse the progressive capillary non-perfusion development which happens in DR. Coming to RISE-RIGHT studies, their post-hoc analysis, all of them showed that capillary non-perfusion can be prevented with VEGF blockade. These are some of the studies which have shown that use of anti-VEGF can prevent development of non-perfusion. So these are some prospective clinical trials in PDR, like DRCR protocol S, Clarity trial, which have been done in PDR, and prospective clinical trials also have been done in NPDR, which are protocol W and Panorama trial. So these are all evaluating clinical outcomes of anti-VEGFs in DR, and a lot of them have evaluated capillary non-perfusion. So a patient of high risk PDR, you can see, has undergone 9 injections of anti-VEGF. Patient has progressed to mild NPDR, regressed to mild NPDR, and has stayed stable over year 2. Similarly, this patient also had high risk PDR and has regressed to mild NPDR. This patient had moderately severe NPDR, level 47, which has reduced to level 20 after 2 years. And another patient who was at severe NPDR stage had reduced to mild NPDR. Again, repeated anti-VEGF injections have been shown. So they have evaluated ranibizumab in this graph. And we can see that with ranibizumab, the DR progression, the levels of DR progression is also stabilized. So DR has not progressed compared to sham. And there are a lot of new therapies which are coming, which are specifically targeting non-perfusion, like semaphorins. So semaphorins, they are neuronal guidance proteins, which are involved in a wide variety of signaling pathways, and they increase the vascular permeability in the retina. So the way ahead is to develop an integrated DR classification with clinically detectable peripheral lesions, angiographic features, and also including the macular status. So in this infographic, you can see that so we can use clinical photograph for detecting microaneurysms, hard exudates, irmas, which are included in the conventional classification. Then on this arm, we can have diabetic macular edema and diabetic macular ischemia, the severity. And with that, we have to correlate capillary non-perfusion, probably with either ultrawide field fundus fluorescein angiography, or we can include ultrawide OCTA, which is coming up. DR classification needs to somehow take into account the treatment effects of patients receiving repeated anti-VEGFs. For example, if a patient has received anti-VEGF and has regressed to mild NPDR, this mild NPDR is not similar to an untreated mild NPDR patient. So we need to include that as well in the classification. So we need to differentiate between treated DR grade and non-treated DR grade. Again, in this endeavor, artificial intelligence and machine learning based platforms can help in the integration. And we need to finally